As we just heard, we want to sort of focus first on the sort of hyperacute, true ICU type of patient first, and then we'll actually talk about the more common problem you encounter, which is bleeding in patients with chronic liver disease. So with that in mind, what we'll specifically review here is give a spectrum, the epidemiology of what's causing acute liver failure in the United States, with an emphasis on acetaminophen overdose, which is the most common thing that you're going to see. We'll talk about a clinical trial I was involved in using IV N-acetylcysteine for non-acetaminophen acute liver failure, and then really boil down into the crux of ICU management of this unique disease entity, which is managing the cerebral edema that these patients get. We'll briefly talk about where things are at with extracorporeal therapy and also the very important role of liver transplantation in the continuum of care for these patients. So first off, we have to all be talking the same language here. So when we say acute liver failure, it's really a unique, narrow group of patients that we're referring to. And this is an uncommon clinical entity. There's probably less than 2,000 cases a year. And what we mean by this is patients who previously did not have any liver disease and present with an elevated INR and mental status changes due to the hepatocellular injury. How quickly do they present? Acetaminophen overdoses present within a few days. Some patients with viral hepatitis can present clinically over a couple of weeks. We're not talking, however, about alcoholic hepatitis, which is very common and oftentimes leads to ICU admissions. We're not talking about someone with chronic hepatitis B who reactivates in the setting of Rituxan or steroids and so on. And we're certainly not talking about the critical care patient who had major illness and then becomes jaundice from intrahepatic cholestasis with DIC. So it's really a unique group of patients with acute illness. These patients can very rapidly deteriorate. They're frequently healthy prior to this, so there's a lot at stake. Cerebral edema and infection can lead to death fairly quickly, and with general supportive ICU care, rates of survival are somewhere between 30 to 40%. However, we do have transplantation. There's over 120 centers throughout the United States that offer this. When you do transplant fulminant hepatitis patients, they do very well, 75% one-year survival, which is a little bit lower than what we see in our chronic patients, which is 85 to 90%. However, we only have about 6,500 livers a year total, and only about 200 patients are undergoing transplant in the United States every year for acute liver failure. And that's probably due to lots of folks not being referred and or eligible for transplant. So in terms of evidence-based management, when you have a rare disease like this, the data to support what you do is oftentimes limited, and this is a perfect example. Again, with 2,000 to 3,000 cases per year, it's very difficult to do randomized controlled trials. What do we know that works? Well, we know N-acetylcysteine for sure works, was actually tested in the 80s, and is the standard of care for acetaminophen overdoses across the board. I think I'll show you some data that it may also be an evolving therapeutic option for patients with non-acetaminophen acute liver failure. H2 blockers in relatively small studies were shown to reduce the rate of GI bleeding. CVVH is much better tolerated in this patient population than hemodialysis. And in a study of 30 patients, mannitol reduced intracranial pressures compared to no mannitol. Now, what doesn't work? We actually know more about what not to do. We don't want to give steroids in this group of patients as a sort of anti-inflammatory, non-specific immunomodulatory therapy. They don't work, and in fact, they increase your risk of infections. Decontamination of the gut with poorly absorbed antibiotics doesn't help. Charcoal hemoperfusion outside of the body with a charcoal filter doesn't work. And there's been 2 recent trials in the last 5-6 years using a bioartificial liver with porcine hepatocytes, which also didn't work, and then a simpler circuit using albumin dialysis in series with hemodialysis also did not improve outcomes. So getting back to our approach to this in a systematic way, you first need to know what's causing the acute liver failure. And you start with the history, and you're particularly looking for acetaminophen or acetaminophen-containing products or other products like that in the history. You want to look for viral hepatitis rapidly with viral serologies. And then you're going to have a whole laundry list of other things to consider. Autoimmune hepatitis can present with fulminant liver failure. It's oftentimes more indolent and chronic as an outpatient. Pregnant women in their third trimester can get fatty liver pregnancy, toxemia, and HELP, and they can get hepatic manifestations. Very rarely you'll see fulminant disseminated herpes infection afflicting the liver. Same thing with CMV. You will occasionally see breast cancer, hematologic malignancies presenting in a fulminant way with liver involvement. Wilson's disease, about 1 in 30,000, can affect young people and present with fulminant liver failure. Budd-Chiari, where you lose hepatic venous outflow rapidly, can cause acute liver failure. And then rare instances of rhabdomyolysis, heat stroke, and ischemia. Now, we've been studying this as part of a multi-center NIH trial for over 10 years, and this data is constantly being updated. This is from 2008. This is 1,033 consecutive adults from 23 major medical centers around the country. And as you can see here on the far left of this slide, acetaminophen overdose is by far and away the most common cause of acute liver failure in the United States. On the far right side of the slide, indeterminate acute liver failure, meaning that they're PCR negative for all viruses that we know of and all other etiologies, is the second most common cause, unknown. Idiosyncratic drug toxicity, drugs like INH, antibiotics, other sporadic agents can cause fulminant liver failure. Hep B is low. Hep A is even lower, and then you can see the variety of other etiologies. In addition to this slide also demonstrates the likelihood of surviving at 3 weeks without a liver transplant. So you can see that the acetaminophen overdose patients actually do pretty well. 60 to 70% with ICU care will survive and leave the hospital. Patients with Hep A also do quite well with supportive care. Patients with ischemia, they don't die of liver failure, but their underlying cardiopulmonary disease needs to be dealt with. And pregnancy-related acute liver failure patients do well, generally with rapid delivery. So those are the more favorable prognoses or etiologies. And then you can see there's other patients that you really should be worried about if you make a diagnosis. So idiosyncratic drug toxicity, if you have anyone with that who develops mental status changes with coagulopathy, you should be whisking them off to a transplant center because they only have about a 20% likelihood of surviving. Similarly, fulminant hepatitis B patients have a poor spontaneous survival. Autoimmune patients have a poor prognosis. No one with Wilson's disease has been reported worldwide to survive fulminant hepatitis, and indeterminate patients also don't do well. So coming up with etiology begets prognosis very rapidly. In addition to etiology, your clinical exam at the bedside is very important. You can see no matter what the etiology is, the more advanced the encephalopathy, a grade 3-4 patient versus a grade 1-2, has a much poorer prognosis across all etiologies. So another way of looking at this is not only just prognosis, but what can you do rapidly once you make a diagnosis. So as you know, with known or suspected acetaminophen overdose, the treatment of choice is if you have a single time point ingestion is to lavage the stomach, get the tablets out, and give charcoal as well as N-acetylcysteine. If you have a rare case of Amanita mushroom toxicity, there's a role for gastric lavage, IV penicillin, and dialysis to remove the enterohepatic circulated toxin. Autoimmune hepatitis theoretically can be treated with steroids, although in our experience, they don't rescue many patients. Patients with thrombophilia and Budd-Chiari can be treated with anticoagulation. Fulminant Hep B patients, remember I told you only about 20% are going to survive without a transplant, but it's worth trying an oral antiviral. Fulminant herpes, if you can make the diagnosis pre-mortem, you can treat those patients with acyclovir pregnancy. The board exam answer is almost always delivery of the fetus to improve the outcome in the mother. And then again, theoretically in Wilson's disease, if you could chelate up that free copper, you may improve outcomes, but that's not been proven to date. So acetaminophen is the one entity you really need to know the most about. It's the most common, as you're going to see it. And this is data from our study group showing that it's over 50% of the cases through 2004, and actually through 2009, it's still at over 50% of the cases that we're seeing. Now, how do you make a diagnosis of acetaminophen hepatotoxicity? You go back to the history. How much did you take? Well, how much is too much? This is where it gets a little bit unclear. We used to think you had to take 10 grams, 20 grams, and we're seeing more and more cases of patients who took 5 grams, 6 grams, 8 grams in a single time point ingestion. There's also lots of individuals who use acetaminophen chronically over many days in multiple compounds and so on. If you have an intercurrent illness where you deplete your hepatic glutathione, that may predispose you in particular to acetaminophen overdose, and alcohol may also rev up your P450 system and enhance your metabolic profile to toxic metabolites. So clinically, you look for a history, but if your patient's encephalopathic, you may not be able to get it. So you're looking for high transaminases. Most of these patients have AST and ALT levels greater than 1,000, but so do fulminant Hep A's and fulminant Hep B's and ischemia patients. So you want to then say, is it due to acetaminophen? So you can look for a serum acetaminophen level, and you're all familiar with that Rumac nomogram. But that only applies to patients with single time point ingestions. And if you have someone with a high bilirubin level, if your lab uses a colorimetric assay, you may get a low-level reading on acetaminophen, even if it wasn't present. So this is the Rumac nomogram. Again, you know how to interpret this, but you have to have a single time point that you can calculate the relevance of the serum level of acetaminophen compared to the time post-ingestion. Anyone who falls above the line should be admitted and treated with NAC. You're probably going to also admit and treat some of the other patients below the line, but they probably won't be coming to the ICU. They may just be going to a medical floor. When you go back to the original data almost 30 years ago on using NAC, in this study, everyone got NAC, and when they used it across the board, less than 1% of individuals died. And the people who didn't do well tended to have high transaminases and the delay in giving NAC. So what is NAC? You're all familiar with this. It enhances total body glutathione stores, but probably most importantly within the liver. You most commonly give this orally as a loading dose followed by a maintenance dose over 72 hours. But you're going to cause some GI toxicity, and some patients won't be able to keep it down. In 10 to 20% of individuals, you can use antiemetics and so on. But there is a newer formulation, was approved a couple years ago, called IV N-acetylcysteine, or trade name is Acetadote. We tend to reserve that for patients who have contraindications to giving it orally. So if you had a short gut, if you've got an ileus. In pregnancy, we like to give it just to make sure we get the highest possible blood levels that will hopefully cross the placenta and also treat the fetus. To give IV, the dosing is different. It's 150 milligrams per kilogram in D5W, then a 50 milligram per kilogram dose, and then followed by a maintenance infusion of 125 mg per kg for 19 hours. When you read the package insert, it's only approved for 24 hours of use. However, in clinical practice, we usually go for the full 72 hours. Beware when you're giving an IV sulfa drug, you may cause hypersensitivity reactions with bronchospasm, rash, and you, of course, can get some nausea. And you need to be very careful if your patient has overt sulfa allergy or known arrhythmias. So when we look at the acetaminophen-related acute liver failure patients, we find some interesting things. Across the U.S., there's 60,000 cases of acetaminophen overdose per year. Majority of those people get discharged and do well with standard medical therapy. So we're talking about the top of the iceberg here of the patients who get to the point of coagulopathy and mental status changes. So when you look at that group, you have a clear-cut overrepresentation of non-intentional cases. So in our database, we found that nearly half the cases who had acute liver failure, not just acetaminophen overdose, but acute liver failure due to acetaminophen, were non-intentional therapeutic misadventures. And those patients look a little bit different. They tend to have lower transaminase levels. They still took very high doses of acetaminophen, a mean of 34 grams compared to 29 in the intentional overdose group. When you look at the blood level of acetaminophen, though, it tends to be lower, and it's probably because they've been overdosing over several days as opposed to a single time point ingestion. Many of these patients were confused and taking multiple products containing acetaminophen, usually for analgesic purposes. We find that narcotic acetaminophen congeners are most commonly implicated in this group, with Vicodin being the number one culprit. We were worried because these patients tend to have more advanced encephalopathy when they first present, and I showed you that slide indicating that advanced encephalopathy begets a poor prognosis. So the proportion, interestingly, who got listed for a transplant or actually underwent transplant was the same. And it may have been because the narcotic and the other products that they were taking led to nonspecific mental status changes, and it wasn't all cerebral edema. And the overall survival actually is similar in patients with non-intentional overdose and intentional overdose. So getting back to the ICU, you've looked for common causes. You're hopefully making a diagnosis or working towards a diagnosis early on. You need to monitor and manage this patient carefully in the ICU. We generally get blood tests every 8 hours. What are you going to get? You're going to get liver biochemistries. And the most useful prognostic factor is the INR and factor V levels to see what the trend is over time. Over 40 to 50% of these patients will develop renal failure, so you need to be monitoring that. Blood gases are very useful, particularly for prognosis with acetaminophen patients, and arterial ammonia levels also appear to have some prognostic significance. You heard about glucose in the prior talk. These patients are prone to hypoglycemia due to rapid liver failure, so you don't want that to happen. You want to be supplementing with D10 or D50 as needed. And a common question comes up is, should you biopsy these patients to see how much necrosis there is to help you with decision making? The answer is no. That's been done before. It's risky. You have to sedate the patients, and it doesn't change clinical management. So we don't recommend liver biopsy in these patients. So infection is going to happen. Daily surveillance cultures. Remember, your liver has the largest number of macrophages in your body, and you're not only losing hepatocytes, you're losing reticuloendothelial function rapidly. Bacterial infection will occur in about 80% of these patients, bacteremias in 25%, respiratory pathogens. And then in your patient who's persistently febrile on broad-spectrum antibiotics within a couple days of admission, you really should be thinking fungemia. You'll see it in about 20% of these patients, and they may just simply have fever, hypotension, or unexplained or rising leukocytosis. So what do? We recommend broad-spectrum preemptive antibiotics in these patients because of the frequency of bacterial infection, cephalosporin plus quinolone, or quinolone plus vancomycin. We don't want to be using aminoglycosides in this particular group of patients because of the frequency of renal failure. And beware that fevers to 102 and 103 can lead to worsening of mental status changes, and so you really want to avoid fever in these patients. What about the coagulopathy? This is a practical problem. It's multifactorial. They oftentimes have low platelet counts due to a variety of mechanisms. By definition, they have hypoprothrombinaemia as part of the syndrome. And if you look, they will have positive DIC panels in almost all of these patients because of poor clearance of the products of coagulation through the liver. Interestingly, only 10% of patients, though, develop clinically significant bleeding. It's most commonly in the GI tract and mucosal surfaces or at line puncture sites. We do recommend, as I told you before, either H2 blockers or these days PPIs, although PPIs haven't been studied specifically in this setting, to reduce the risk of GI bleeding and stress ulcer bleeding. We don't recommend routine prophylactic transfusion of FFP or platelets. We reserve that for prior to procedures or if someone is actively bleeding. And then your targets are to get your INR under 1.5, platelets greater than 50. And if your patient has hypofibrinogenemia, you also want to supplement that. So what about NAC and non-acetaminophen acute liver failure? There's a lot of theoretical reasons to think that this drug may help all patients with liver failure. It's a potent antioxidant. It's a vasodilator. There's some small physiologic studies indicating that it may improve tissue oxygenation, and we're all familiar and comfortable with using this drug. The cons are, when you study this in advanced encephalopathy patients, it really didn't appear to do much. You can cause hypotension, you can have anaphylactic reactions, and there was no randomized controlled trials to support your therapy. There is now one study that was just published last year, multi-center randomized double-blind study of IV NAC versus placebo given over 72 hours for adults with non-acetaminophen acute liver failure. We enrolled a total of 173 patients. Out of 828 that were screened, it took 8 years to do this study. The etiologies of acute liver failure were autoimmune, drug-induced, Hep B, indeterminate, and a handful of other things. Patients were randomized, stratified by site and their coma grade, and they continued to receive standard of care at the local hospital, including liver transplant if it was felt to be in their best interest. The primary outcome for this study was overall survival at 3 weeks. There was a variety of secondary outcomes we also looked at, and we, of course, anticipated that NAC would do better than placebo. So here's the data. On the far left, you can see that overall survival was not statistically significantly different in the patients in the orange who received NAC versus those who received placebo, so it did not reach the primary endpoint, but it did reach some very important secondary endpoints. So in the second bar, you can see that transplant-free survival, so that is surviving at 3 weeks without needing a liver transplant, was significantly better in those who got NAC versus those who got placebo, and this benefit was most apparent in the patients who had early-stage encephalopathy at entry and with grade 1, 2, whereas we really didn't see any difference in the more advanced encephalopathy patients. We actually followed these patients out to a year, and the likelihood of needing a transplant also at 1 year was lower in those who received NAC. So what can we say? We didn't hit the primary endpoint on this study, but we did improve transplant-free survival, which I would pose as a very important secondary endpoint. This was particularly of benefit in patients with early-stage encephalopathy. I don't have time to show you the data. There was a trend towards improved length of stay, but interesting, not in SOFA scores and other evidence of multi-organ failure. NAC was associated with more side effects, but it was like 12% versus 4% in terms of nausea, vomiting, and rash. So at this point in time, what can we say? It's not FDA approved for non-acetaminophen acute liver failure. I think because the drug is available, you could consider using it in patients, particularly with early-stage ALF. And stay tuned because there's a pediatric trial that's probably going to be reported at the end of this year or next year to see if we can confirm similar results. So transplant is very important early on. This consists of having a hepatologist and transplant surgeon rapidly evaluating the patient. And we go back to that second slide I showed you. What's the etiology? What's the grade of encephalopathy? We also then are looking for other issues to consider someone's a viable transplant candidate, their medical history, compliance, ability to tolerate immunosuppression, and so on. We get a whole bunch of labs. We want to know if they're actively infected or not. We got to make sure that their heart would tolerate major surgery. And you can usually do a transplant evaluation in anywhere from 6 to 12 hours. While you're thinking about transplant, you still have to clinically be managing your patient. And again, cerebral edema is the tricky physiology here. You can end up with permanent irreversible neurological damage, and you have to manage hemodynamic, respiratory, cerebral, and renal factors all at the same time to optimize brain perfusion. And so what's the pathophysiology here in acute liver failure? It's not entirely clear. There's two leading hypotheses. The first one is the ammonia hypothesis, that with a failing liver, you don't clear ammonia through the liver. Arterial ammonia levels rise. They cross the blood-brain barrier. The ammonia gets taken up by glutamate and gets converted to glutamine. That then stays within the confines of the CNS and is an osmotic agent and draws fluid into the astrocytes. So that's believed to be a component of the mechanism of brain swelling in patients with acute liver failure. Further on in the syndrome, there's probably also a problem with hyperperfusion of the brain and loss of autoregulation as well. So what does this look like clinically? Well, we talk about grade 1 through 4, the old HE scoring system. These patients oftentimes can fool you, particularly if they're otherwise intact, bright individuals. They may just have a little bit of slowed mentation, a little slight change in their personality, level of consciousness, no obvious physical signs of cerebral edema. What do we recommend? You want them in the ICU. You want a quiet environment. You don't want to be giving sedatives and hypnotics to help them sleep because they're not going to metabolize them and they can get worse. And you need to be working them up for what's causing liver failure, starting specific therapies, and thinking about transplant early on. Grade 2, they start to get more disoriented. They may be drowsy. They may be inappropriate. They may start to show physical signs like asterixis, clonus, etc. Here now, because remembering that they have coagulopathy, they could also spontaneously bleed intracranially, so you usually need to be thinking about getting a head CT. And if they're getting progressively more and more confused and you're worried about their airway, you're oftentimes going to need to intubate. And again, as they're getting sicker, they oftentimes need to be on antibiotics, and you need to be thinking about what's your next move. Grade 3 patients are more confused. They're invariably intubated at this point. You oftentimes have to have concomitant hemodynamic and renal monitoring, and you need to be thinking about ICP monitoring. Some of these patients can develop seizures, and again, are you going to be doing a transplant? What about hemodynamic monitoring? Well, swans, I know, are not in vogue these days, but this is a patient population you may want to consider if you can safely place one, because they oftentimes, these patients may be volume depleted or hard to tell what their intravascular volume is. They may be hypotensive and on pressors and also have poor renal output. So swans can help you. And if you're going to need to dialyze your patients, you're going to want to use CVVH over hemodialysis because it's going to be better tolerated. What's your goals? Your goals are to maintain brain perfusion in these patients. So cerebral perfusion pressure of greater than 50 to 60 is the goal. And the only way you can calculate that is you know what the MAP is, but you need to know what the ICP is. This is very difficult without an intracranial pressure monitor. If you do need to use pressors, there's some physiologic data to suggest Levophed should be preferred over vasopressin. There's some simple things you can do to avoid exacerbation of cerebral edema, like not having your patient strain Valsalva or with suctioning vigorously. Keep the head of the bed up at 20 to 30 degrees. And if you need to use PEEP ventilation, try to minimize it. So ICP monitoring is really useful in this clinical setting because, again, the clinical signs and CT scans are oftentimes insensitive. And, again, the ventilator can throw off some of your interpretation with the subsequent sedation that you need. However, neurosurgeons push back and say, show me that by my putting a monitor in and helping you will improve the outcomes of our patients. And there are no data to show improved outcomes. And, of course, there's a risk of bleeding, as I mentioned, in doing anything in these patients. So we retrospectively looked at data from the acute liver failure study group. This is not a randomized controlled trial. It's purely observational retrospective data. 92 patients had an intracranial pressure monitor placed. 240 did not. You can see we tended to place monitors more frequently in younger patients. The INRs were high, 3.3 on average in both groups. Majority of patients were intubated. Majority were sick with renal failure. And the majority of people who we put monitors in were listed for a transplant. And here's what happened. Again, non-randomized study, purely observational, but the patients in the dark gray who had an ICP monitor placed were able to provide more ICU treatments because we knew what we were doing with the CPP having the ICP. So we used mannitol more frequently, we used barbiturate coma more frequently, and we used pressors more frequently to maintain cerebral perfusion. Well, what about outcomes? Well, it turns out that on the 80 patients who underwent transplant, whether they got a monitor or not, their likelihood of surviving at 3 weeks was actually the same. Those who were listed and not transplanted, it was similar, and those who were not listed and also got monitored versus not was similar. So we can't show an improved survival benefit, but we can certainly show that we can do more therapies in the ICU. So if you're going to consider an ICP monitor in your patient, you need to reserve this to your patients who have advanced encephalopathy. Your neurosurgeon is usually going to want another head CT to make sure there's no spontaneous bleeding. And they're going to ask you to correct the coagulopathy. And this is very challenging, particularly the INR. So what's recommended here is you don't want to overflood these patients with fluid because you can actually make the edema worse, but you need to give all of the clotting factors first, which is what you give in FFP, and we recommend not going over 4 units because of the volume with FFP. And we oftentimes need to introduce a secondary procoagulant, which is recombinant 7A. This is not FDA approved for this indication. This is purely from clinical practice, and as you know, recombinant 7A promotes localized clot formation with tissue factor release. And in one small retrospective study, 100% of patients corrected their INR versus 0% with FFP. and 100% of patients were able to have an ICP safely placed versus 38% with just FFP. But you don't want to be giving recombinant 7A to anyone who has thrombophilia, cancer, DVTs, pregnancy, etc. Again, you have to give FFP first to get all the clotting factors on board, and then you give this as a bolus over 5 minutes immediately prior to your procedure, and it provides you about a 4 to 6 hour window, but it's very costly and not approved. What are some other things you can do in the ICU for these patients? Hyperventilation. You can see on the far left here that these patients, before they were hyperventilated, had no intracranial autoregulation of blood flow, whereas once they were hyperventilated on the right, they had restored regulation of intracranial blood flow. So that's a relatively simple maneuver to get the PCO2 down to 25 to 28 on the ventilator. That's usually not enough. You're going to need to move to the next step, which is mannitol. The problem here with mannitol is it will draw fluid into the intravascular volume, but if 40 to 50% of patients already have renal failure, you have to be careful. Pentabarb coma is usually the third step. You have to be careful when you use this because you can induce hypotension, which will again reduce cerebral perfusion, and you need to monitor these patients very carefully. What about refractory cerebral edema? You've done everything, you're waiting for a liver. Hypothermia is of theoretical interest here, lowering the body temperature, the core temperature to 33. How do you get there? These patients are actually vasodilated, so they can oftentimes cool with just simple cooling blankets. It's very tricky to put intravascular cooling devices into these patients. Arctic suits may also be an option for control. There's one uncontrolled study of 13 patients being cooled and then subsequently getting through liver transplant. But as you know, when you cool any patient, you're also going to induce reflexive shivering, so you have to have these patients either on atracurium or propofol. So there's some potential benefit to cooling your patients with reducing cerebral edema, but there's also potential risk of causing worsening coagulopathy, infection, and cardiac arrhythmias. And also the problem is, okay, so you've cooled them, now what do you do? When do you rewarm? How rapidly can you bring the temperature up? How do you know that your patient's doing better? None of these questions have been answered. We were trying to get a grant on this, but we're unsuccessful. I think we're going to be looking at case series going forward. So your patient you're considering for transplant, who should you be considering right off the bat? Your acetaminophen overdose patients who have persistent lactic acidosis, very high INRs, renal failure, or advanced encephalopathy are the worrisome ones. And then the King's College criteria would suggest that everyone else can be lumped together, although I don't really agree with that. And I think we have better etiologic data for prognosis. In any event, your patients are deteriorating. They're in grade 4 coma. What are you going to do? You want to avoid the ICP surging over greater than the MAP for 30 minutes because it can lead to irreversible brain damage. Despite your best efforts, some of these patients will go on to develop brain death, and you may need to use a technetium scan to diagnose that. And it's always a fine balance between knowing whether you should continue to push ahead in a young patient and transplant them versus saying it's too late, and that we oftentimes struggle with this. But we don't proceed with transplant if they have uncontrolled sepsis, multi-organ failure, if they've had intracranial bleeding, or obviously already achieved brain death. Who do you transplant? Well, again, it's difficult, it's tricky. The good news is that you can put these patients right at the top of the liver transplant waiting list. It's called status 1A. You can then draw livers oftentimes from a region as opposed to an individual OPO. You try to get an ABO-compatible liver, but it still takes 3.5 days in the United States to find a liver on average. And again, as I mentioned before, about 200 patients gets transplanted every year with generally good outcomes. And let me finish off here with looking at the future to say, how can we do better? Can we remove toxic substances being released by these necrotic livers? It's been very attractive, a lot of experimental animal work and human work for years on this. The most recent version was using albumin dialysis. This was done in France in 2004 to 2007. 102 patients were randomized. 38% of them were acetaminophen overdoses. They were very ill. 32% were intubated. And 68% ended up getting transplanted. But the real problem in this study was they had very quick access to organs. It only took 16 hours to find livers in France. And because of that, the ability to show an intervention like a medical treatment such as albumin dialysis, I think, was impaired. And you can see in the intention to treat numbers, the 6-month survival in the patients who got albumin dialysis, which was a Mars device, was 85% versus 76%. It wasn't significant. And per protocol analysis also wasn't significant. So unfortunately, we do not have an extracorporeal treatment to help with these patients. So to summarize, acute liver failure is a rare but a dramatic illness, an important one to be aware of. Establishing diagnosis quickly is very important to initiate specific treatment and also to guide you with prognostic decisions, referral to transplant centers. I would strongly encourage you to give NAC to any patient that you think could have acetaminophen overdose contributing to their illness. And as I showed you, I think NAC is a probable benefit in non-acetaminophen patients, but we certainly would like to see some confirmatory data on that. Cerebral edema is really important to be aware of and to manage. ICP monitors clearly allow us to provide more intervention but have not shown a survival benefit. And again, hypothermia is by no means an established ICU treatment for this group of patients, but certainly liver transplantation is and is effective for the highly selected patients. So with that, let me stop, and then we'll switch over to the other talk. Thank you.